Let's talk about IVF in a patient with decreased ovarian reserve. Now, there are some nuances and some things that we might do a little bit differently in patients with DOR. We're going to talk about stimulation protocols. We're also going to talk about different add ons that may improve outcomes. When we're thinking about stimulation protocols, one approach, and I know it's one of our favorite
Yes.
approaches, is to do a min stim cycle or a mild stimulation cycle or a mini IVF cycle
Or low dose stim.
or low dose stim cycle. There are so many names for it, but they're all kind of the same idea. The premise is that you are using a way lower dose of stimulation medications to do an IVF cycle in comparison to the conventional super high dose protocols.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Welcome back, superhumans. Today we're talking about a really common topic, or a topic that we get a lot of questions about on social media. We're going to be talking about decreased ovarian reserve. Now, sometimes it can also be called diminished ovarian reserve, and we also often refer to it as DOR, and we're going to go through that. In this episode, we're going to talk about what is DOR, as well as how somebody with DOR can maximize their fertility, both via lifestyle and vitamins and planning for natural pregnancy, as well as when we're contemplating IVF in terms of different protocols and add-ons in therapy.
Unlike other cells in the body, like hair cells or skin cells, eggs are unique and different in that a woman is born with the number of eggs that she's ever going to have. Women do not make new eggs throughout their reproductive life. They ovulate a new egg throughout the reproductive cycle, but they're not making new egg cells. So for this reason, as women get older, the number of eggs decreases over time, as well as the quality of eggs also decreases over time. This is genetic. In other words, for some women, this decline can be very steep, and some women can find themselves completely menopausal before age 40. And for some women, the decline is less steep, and they can have good ovarian reserve until the natural age of menopause, which is about age 52. Regardless, for all women, we do see a significant decline in egg quality, which equals a decline in pregnancy rate, fertility outcomes through IVF cycles as women get older.
All right, so what is decreased ovarian reserve, or how do we define decreased ovarian reserve? The European Society of Human Reproduction and Embryology, or ESHRE, came out with a list of criteria in 2011, and they called it the Bologna criteria. And they really did this because they were trying to standardize the diagnosis of poor ovarian reserve or decreased ovarian reserve in the context of IVF. Once everybody can agree on a definition, it's much easier to study it and to compare different studies and research looking at decreased ovarian reserve. According to this criteria, a patient is considered a poor responder or to have DOR if they have at least two of the three features present. The first thing that they look at is the age, as well as other risk factors for decreased ovarian reserve. So for age, they're looking for women who are over the age of 40. Other risk factors might include a history of some type of ovarian surgery, a history of having chemotherapy for cancer treatments or radiation therapy, especially to the pelvis, or some sort of genetic factors that we know are associated with reduced ovarian reserve. The second feature that they look at is a previous poor ovarian response, meaning that if somebody has done a previous stimulation cycle, let's say for IVF, and they retrieved 3 or fewer eggs despite the use of an adequate stimulation protocol. The third feature included in the criteria are specific thresholds for egg reserve testing. That means an antral follicle count fewer than, let's say, 5 to 7 follicles, or an AMH, which stands for anti-Mullerian hormone level, less than about 3.6 to 8 picomoles per liter. If somebody has 2 or 3 of these criteria, then they meet the definition of decreased ovarian reserve.
It's important to know that a diagnosis of decreased ovarian reserve does not mean that you cannot get pregnant. I think it's really key to emphasize that. All that we're saying when we're giving patients a diagnosis of decreased ovarian reserve is that when we're stimulating those ovaries to retrieve eggs, because of this diagnosis, we know that we're not going to retrieve a high number of eggs. We know that we're looking at retrieving anywhere between 1 to 3 to 5 eggs, depending on other criteria that your doctor will discuss with you. I think this is key because a lot of times people hear this diagnosis and they immediately assume that natural pregnancy is out of the equation. They immediately assume that getting pregnant with their own eggs is out of the equation. And that's not what it is at all. It just means that the number of eggs that you get per IVF cycle is going to be decreased. And as we discussed in episode 14, we know that IVF is a bit of a numbers game. In other words, not every egg that you have will fertilize, and not every egg that fertilizes develops into blastocysts. So ideally, we do want to have a good number of eggs to start with in order to get 1 or 2 blastocysts at the end. But at the end of the day, it's the quality more than the quantity that matters. So even if somebody has decreased ovarian reserve, which means low egg quantity, if their quality happens to be good, either because of a younger age or because of excellent genetics or excellent lifestyle factors, then there is still a reasonable expectation of success from that point of view.
Let's say you have gone to see your fertility specialist and they've given you this diagnosis of decreased ovarian reserve or diminished ovarian reserve. What can you do to try and maximize those odds of success, to maximize the chance of pregnancy? First of all, I think we always need to consider lifestyle. And I think we say this for every condition. I think we said this for PCOS in the past. But really, lifestyle is such a huge factor when it comes to health. It's an important thing to take into account early because changes in lifestyle can take a really long time, but they can have massive benefits down the line. When we're thinking about somebody with decreased ovarian reserve, first and foremost, if you're smoking or vaping, please stop. We know that this is really bad for your eggs, both the quantity and the quality. Also, you should limit the amount of alcohol that you're consuming and consider limiting cannabis as well. We did a whole episode just on marijuana, so you can check that out. That was episode 18. Along the lines of that, we also would suggest taking a look at diet and looking at exercise to maximize health. We did episode 6, which is all about lifestyle factors for women. Another important addition to lifestyle can be vitamins and supplements. On episode 5, we had Dr. Amy, the egg whisperer, as a guest, and we spent a whole episode talking about ways to maximize egg quality. But in brief, my top 3 things would be looking at taking coenzyme Q10, about 600 to 800 milligrams per day, making sure you're getting enough vitamin D, and looking at increasing omega-3 intake.
Remember, we cannot make more eggs, but we are looking at making the eggs that you already have the best that they can be. Like I mentioned before, having decreased ovarian reserve does not mean that you automatically have infertility or that you need to do IVF. Women with decreased ovarian reserve are candidates for IUI and also IVF, and potentially natural conception is still a possibility. However, I think it's important to note that let's say you have somebody with a low AMH level and a low follicle count, and your doctor has diagnosed you with decreased ovarian reserve. You don't have any children yet, and you are looking at building your family, and you're hoping to have 2 children or 3 children. I think it's important to consider IVF sooner rather than later because what we know about decreased ovarian reserve is that it gets worse over time. So if today, let's say at age 37, you have an AMH level that is low, and you're able to conceive naturally or with IUI, and then you come back when you're 39 or 40 trying to have your second child, then we expect this decrease of ovarian reserve to be much worse. And now the quantity is going to be lower, but also the quality is going to be much lower just because you're a bit older. So I think this is a conversation to be had with your fertility specialist. Whether you have DOR or not, I think it's really important to understand right at the offset of your fertility journey, how big of a family do you want? And it is okay to dream big and say, I want to have 2, 3, 4 kids, whatever it is that you desire, so that we can plan for that ahead of time. we're not just looking at one pregnancy, but we're looking at multiple pregnancies. So that would be a reason, specifically in the setting of DOR, to consider doing IVF sooner rather than later.
Let's talk about IVF in a patient with decreased ovarian reserve. Now, there are some nuances and some things that we might do a little bit differently in patients with DOR. We're going to talk about stimulation protocols. We're also going to talk about different add-ons that may improve outcomes. When we're thinking about stimulation protocols, one approach, and I know it's one of our favorite approaches, is to do a min-stim cycle or a mild stimulation cycle or a mini IVF cycle
Or low-dose stim.
or low-dose stim cycle. There are so many names for it, but they're all kind of the same idea. The premise of a minimal stimulation cycle is that we are going to use a much lower dose of stimulation medications or gonadotropins. For instance, let's say a patient has done a maximum dose stimulation in their past. And now, for a subsequent IVF cycle, we're contemplating doing a minimal stimulation cycle. We may end up using a dose of medication that is, a third or even a quarter of what they used previously. The approach aims to retrieve a number of eggs that's probably going to be slightly less or very similar to the number that you would get with that conventional type of stimulation. But the quality of the eggs might be a bit higher, and it also reduces costs because you're using a lot less medications.
Yeah, this is definitely one of those cases where less is more, for sure. And the evidence will support that. This is not just Dr. Weiss and Dr. Garcia crazy talking, because we've had such good experiences with mini IVF. There is evidence to support it. For example, there was a study published in 2007 which looked at mild stimulation, and the study showed that you actually get better oocyte and better embryo quality due to a more natural follicular development. In other words, when you're giving a lower dose of the stimulation, the follicles that are more competent, the follicles that have the more FSH receptors, and the ones that hopefully carry the better quality eggs are the ones that are going to develop. So that would explain why some studies have found that mild stimulation or low-dose IVF can actually yield better egg quality, better embryo quality, and we know that better embryo quality leads to better implantation rate and higher pregnancy rates.
Now, speaking of pregnancy rates, there have been several studies that have shown that these mild stimulation protocols or min-stim protocols can achieve pregnancy and live birth rates that are comparable to those of conventional high-dose protocols. In fact, there was a systematic review and meta-analysis that found no significant difference in live birth rates between these mild stim and more conventional protocols, suggesting that mild stim could be a very effective alternative for patients.
And another study published by Hammond et al. In 2003 showed that mild stimulation is actually more cost-effective for patients. If the cost of the medication is less, you might be able to do more cycles for the same amount of money that you would otherwise, and also leads to the ability to do more cycles, which would translate into higher success rates just for that, but also higher patient satisfaction because of a lower cost and less side effects from the medications.
Now, min-stim cycles may also lead to shorter treatment cycles and may get people to pregnancy faster. Mild stimulation protocols typically involve shorter treatment cycles, typically, not always, but that can actually be way more convenient for patients and, as I said, may lead to quicker time to pregnancy in some cases. And there was a research project that was published in 2007 that found that the overall duration of treatment was shorter in mild stimulation cases compared to these conventional cycles.
So pregnancy rates that are comparable to conventional IVF with a shorter treatment cycle, less cost of the medication, and less side effects. Sign me up for that. What is wrong with that?
Oh, yeah, absolutely. I think that it just takes a lot of discussion and a lot of explanation with the patient to talk about this. As you said, less is more. A lot of patients come into this thinking more is more. If I just take more medications, I'm going to get more eggs. As we say time and time again, more eggs is probably going to lead to better IVF outcomes. But there is a ceiling effect when it comes to decreased ovarian reserve. Sometimes it can be a little bit of a challenging shift to switch to a min-stim IVF protocol. But I think that when you do, and you get that better embryo quality, it is totally worth it.
For sure.
Also, I couldn't find any studies on this specifically, but in my personal experience, sometimes I find min-stim cycles, I actually get more eggs.
Oh, yeah. Oh, yeah.
Yeah. I don't really see that in the literature, but in my personal experience, I've definitely seen that.
I have had many patients that responded way better to mouse stimulation than the conventional stimulation with, you're right, making more eggs and more embryos. For
For
sure.
sure. We are big supporters of Minston cycles here at Margaret Fertility.
Another protocol that we use with people with decreased ovarian reserve is what is called a dual stem or duo-stim stimulation. Basically, what this means is 2 egg retrievals in 1 month or in 1 menstrual cycle. We would do a stimulation starting on day 2 of the cycle. That would be the follicular phase of the dual stem. Then you do a retrieval about 10 to 12 days after starting medication. And about 5 days after retrieval, you start the medication again. And you're looking at what is called a luteal stem. So that means the second part of the menstrual cycle. With the dual stim, we're not able to do an embryo transfer, not a frozen embryo transfer, not a fresh embryo transfer. So this is a protocol where we know that we're committed to making embryos and freezing them. Whether or not we do genetic testing is a separate story, but we absolutely have to freeze them. And one of the benefits is that you're doing 2 retrievals in a shorter period of time, because we know time is of the essence when we're dealing with decreased ovarian reserve. And there is also some theories that sometimes the luteal phase of the stimulation can lead to more eggs and better eggs. And that has been our experience in some cases, not in all cases, but certainly in some cases, we've been really impressed by the quality and quantity of the eggs in the luteal stem.
Certainly, there's been a lot of literature about this dual stim approach. It's a little bit newer than the min stim approach. There was a study in 2016 that showed that a dual stimulation in a poor prognosis patient or somebody with DOR led to a significantly higher number of eggs and embryos available for transfer. And again, that can be, as we said, really important for someone where time truly is of the essence.
There was another study published by Kwan et al. In 2014 that looked at cumulative live birth rate. So not just the pregnancy rate per embryo, but cumulative over multiple cycles. And it noted that the live birth rate was higher in patients that underwent dual stim compared that use a traditional single stimulation cycle.
Dual stimulation cycles can also lead to shortened time to pregnancy because you're allowing patients to undergo 2 retrievals in 1 cycle. So it's in a way more efficient if you want to think about it that way. And there was a study that was published in 2013 that showed exactly this. The time to achieve this cumulative clinical pregnancy was significantly shorter with dual stim than conventional stimulation.
When I started doing my training in reproductive endocrinology and infertility many years ago, I'm dating myself now, but we're talking 12, 13 years ago, the idea of doing a luteal phase stim was unheard of. Everybody thought that if you stimulate those ovaries in the luteal phase, that the world was going to break apart, the sky would fall off, and we would all die. But studies actually show that you can do a stimulation in the luteal phase of the cycle, and that the embryo quality obtained from eggs in the follicular phase, it's very similar to the embryo quality obtained in eggs in the luteal phase. Like I said earlier, in my experience, sometimes we get better eggs with the luteal phase, but studies would show that the results are comparable, which is basically evidence to support that you don't have to feel like you're compromising on egg quality or embryo quality by doing a luteal stim as part of the dual stim cycle.
Now, when I was going through training, which was a few years ago as well, not quite as many as you, but a few years ago, we used to do luteal phase stims or random start stimulation cycles on patients undergoing egg freezing for fertility preservation, for urgent fertility preservation cases. So patients who are about to start chemotherapy, let's say for cancer treatments. And we would start stim at any point in the cycle and we would still get eggs. And so it makes sense that if we would do that for those patients, why not do it for all patients? The only real downside, I guess, from the patient perspective is that when you're doing a dual stim cycle, you can get funny, weird breakthrough bleeding, and you can get sort of a pseudo period while you're doing your stimulation or have a lot of spotting and bleeding through that stimulation because of the hormone mix that's going on in the body. When I counsel patients about that and I remind them that that might happen and that's okay and that's normal, it's not necessarily a big deal.
A study published by Pollack et al. In 2020 actually demonstrated that dual stim was very well tolerated by patients, did not increase the risk of ovarian hyperstimulation syndrome, and did not increase the risk of any of the side effects that we normally hear about in an IVF cycle. So shorter duration to pregnancy, ability to do more retrievals in a shorter amount of time, potentially ability to get double the number of eggs that you would get otherwise. Very well tolerated for patients. I think it's a win-win in the right patient population.
Absolutely, for sure. You know what? It's great to have options and it's great to have different things to try and to consider, especially for patients with decreased ovarian reserve, because the clock is ticking for everyone, but it's ticking extra loud for these patients,
Yes.
right? Like it's palpable in these appointments that we have with patients, this clock looming over all of us. It's not to say that this is necessarily the perfect answer or that either of these protocols is going to lead to amazing embryos. I mean, I know we've both had experiences where we've done dual stem cycles or min stem cycles and they've gone super well, exceeded expectations based on the AMH and the diagnosis of DOR. And then sometimes we've done similar cycles a second time and you can end up with really not great results either and not making many eggs or not making many embryos. And so there is a lot of variation cycle to cycle for patients. And I think it's especially big, that variation, when patients have a low egg reserve. It's really about individualizing to the patient and discussing expectations and making it clear that I don't have a crystal ball. I don't think Dr. Garcia has a crystal ball that I've ever seen.
No. I wish I did.
I think Dr. Shan has one in her office, though. Like, actually, there's an actual crystal ball in her office.
I don't think it works that well.
It doesn't, yeah. She hasn't figured out how to make it work. But it's just to say that we try these different approaches. We have different things that we can do, but there's no clear path or no clear answer for patients with decreased ovarian reserve.
So far, we've talked about two different protocols, the low-dose IVF and the dual stem. Now we're going to talk about other things that we can use in our toolkit to address decreased ovarian reserve. One of the things that we use is the addition of androgens or testosterones or male hormones. Testosterone is an androgen hormone and it plays several roles in the ovary. It is crucial for normal ovarian function and fertility. For example, in the follicular development, testosterone is a precursor for estrogen. The granulosa cells in the ovarian follicle have to convert testosterone to estrogen via the enzyme aromatase, and we know that estrogen is essential for the growth and maturation of the follicles. During the actual follicular growth, low level of testosterone can promote follicular growth and development and help with the early stage of follicle maturation. So even though it's what is considered a male hormone, we do know that it actually has a crucial role in ovarian function for females.
We also know that with increasing age and decreasing egg reserve, that testosterone levels in women go down naturally. When women are perimenopausal or entering menopause, not only are their estrogen levels really low, but their natural testosterone levels are really low.
One of the things is the addition of androgen hormone or testosterone. Testosterone plays a crucial role in the development of follicles and the maturation of eggs. So even though it is a hormone that is typically associated with males, it actually plays a very important role in female reproduction as well. For example, we know that testosterone is a precursor to estrogen. So the granulosa cells in the ovarian follicles convert testosterone to estrogen with the use of the enzyme aromatase, and estrogen, it's important in the development of the follicles. And testosterone also has an important role in the final maturation of eggs as well.
As people with ovaries are getting older and as the egg reserve goes down, we know that endogenous, meaning the androgen levels that are already in the body, go down as well. When women are hitting perimenopause or menopause, not only is the estrogen level low, but we know that their testosterone level can also be low. In the world of add-ons, as for an IVF cycle, when we're thinking about testosterone, we have two kind of main formulations that we use. So there's DHEA, which is an oral pill version of testosterone, as well as androgel, which is a testosterone gel. Now, it's important to note that they are off-label uses of these medications, meaning that Health Canada has not approved these things specifically for improving egg quality in IVF. A lot of the research, a lot of the literature around androgel typically suggests using it for about a month or so, or 2 months, maybe even 3 months, prior to the IVF stimulation. Now, some studies also suggest using it during the stimulation as well, but the idea is that you want to use it for a short period of time, sort of before stim and maybe during stim, to improve the quality of the eggs. It's kind of nice because it's just a clear gel. Patients get a little pump bottle and they can just use it and you just smear it on your upper arm or your upper leg. It's really easy to use. It's not another injection medication. The studies that looked at DHEA more often will talk about using DHEA for at least 3 months prior to an IVF stimulation. If you're thinking about being time efficient, androgel might actually be a lot more efficient because you only need to use it for, let's say, 1 month before your stim, or DHEA, you're using it for 3 months. And just recently, about a month or so ago, there was a Cochrane review which was published that showed that pretreatment with testosterone gel, like androgel, likely improves live birth and clinical pregnancy rates in women undergoing IVF who have been identified as poor responders. What's also interesting is that when they looked at DHEA, they felt that it made little to no difference in live birth or clinical pregnancy rates. Personally, I'm a much bigger proponent of using androgel over DHEA. Cochrane Review agrees with me, so I feel pretty smart about that.
Another addition in the toolkits of tricks that we use to treat women with decreased ovarian reserve is the off-label use of growth hormone. Growth hormone is thought to enhance ovarian response through several mechanisms. It can improve the sensitivity of the ovary or the sensitivity of the follicles to the follicular stimulating hormone, which is the medication that we give you to stimulate the ovaries. It might have an impact on improving the quality of the egg through metabolic and developmental pathways within the eggs. And also it's associated with insulin growth factor, which we know plays a role in follicular development and egg maturation. There have been a few studies looking at the use of growth hormone in reproduction. For example, there was a study published by Tesarik et al. In 2005, and it was a randomized controlled trial where they used growth hormone supplementation, and they noticed that in decreased ovarian reserve patients, growth hormone supplementation led to better ovarian response and a higher number of eggs retrieved. Another meta-analysis published in 2017 confirmed this finding, showing that growth hormone supplementation increased the number of eggs and the number of mature eggs in people that were diagnosed with decreased ovarian reserve.
We've talked about egg number, but then there's also evidence to show that growth hormone may enhance embryo quality and thereby improve pregnancy rates. In 2011, a Cochrane review reported that growth hormone adjuvant therapy might improve the clinical pregnancy rate and the number of high-quality embryos in women with poor ovarian reserve. There was another systematic review from 2010 that found that growth hormone might also improve embryo quality and again improve the likelihood of clinical pregnancy in women undergoing IVF. Now, whenever we're thinking about IVF, the goal is a live birth, right? That's what we really care about. Making more embryos is good as long as you improve live birth. There were some studies that actually looked at growth hormone and specifically live birth. Shang et al. In 2018 found that growth hormone supplementation in poor responders did result in higher live birth rates compared to controls. And there was another meta-analysis published in 2009 that showed that growth hormone treatment could improve live birth rates in women with previous poor ovarian response.
Now, growth hormone is expensive, unfortunately. So it's important to look at the cost effectiveness. In other words, you're spending extra money and you actually see your return of investment. And there was a study actually looking at that. It was noted that while it's costly, the study suggests that there is a significant improvement in outcome, so it justified the expense, especially when women have decreased ovarian reserve and would otherwise have to do multiple cycles of IVF in order to achieve a live birth. There was a cost effectiveness analysis to the growth hormone that was positive for patients to be on it to hopefully improve their chances of live birth.
It's important to note that fertility doctors as a whole have not really agreed on the best protocol or the best doses for using growth hormone. Looking at all these different studies, it's typically administered somewhere from 4 to 12 international units per day, starting from either the beginning of the stimulation cycle, maybe a few days before, and typically stopping the day of the trigger. Growth hormone is often used in combination with different kinds of standard ovarian stimulation protocols, and you can use it in addition to a minimal stim cycle or a dual stim cycle, or you can use it in combination with testosterone. All of these things can potentially be combined to maximize a cycle.
Growth hormone is very well tolerated. Some of the potential side effects include joint pain, swelling. Some people may develop insulin resistance, but for the most part, patients do very well on growth hormone and there are minimal side effects. However, the long-term data is limited. This is a fairly new off-label medication used in the fertility world, so we don't have really long-term data looking at 10-year, 20-year risk down the line of having used growth hormone during your stimulation cycle.
Another thing that we should consider when we're thinking about diminished ovarian reserve, or something that should enter into the conversation, is that for patients who have, let's say very diminished egg reserve, might also be time to think about, or time to at least talk about, donor egg. I think everybody has a slightly different philosophy on this. When I'm talking to patients about different treatment options, I will often mention or bring up the concept of donor egg sooner rather than later, just because I want to plant that seed into the patient's mind that that is an option that is out there, and that I can talk about that, and that if they ever have any questions, that they can come to me and ask those questions. Certainly when we're thinking about things that you can do to maximize pregnancy rates if you have decreased ovarian reserve, donor egg is absolutely an option, and in fact probably actually has the highest pregnancy rates of all.
I know it's not the way everybody envisions setting their family at the beginning of their journey, but from my experience, once you've gotten there and you sort of embrace this as being an opportunity for you to be able to carry a pregnancy, to give birth, to hold a child in your hands, it can really be a wonderful experience. And here at American Fertility Center, we have an excellent donor and surrogacy program. And actually, we've had a few patients from the donor and surrogacy program that have contacted me wanting to come on the podcast and tell the story, because they feel exactly that they've gone from dreading just hearing those words to really embracing that. And they really want to talk about what that's like. So I'm excited for those conversations.
All right, let's do a quick fire round.
My favorite part of the podcast.
Yes, where we're going to go back and forth asking questions here, okay? I want to know whether you actually pay attention to what I say.
Every word. I hold on to every word you say.
So I mentioned this a little bit earlier in the podcast, but what AMH level is considered decreased ovarian reserve or diminished ovarian reserve in the Bologna criteria?
Usually an AMH level of 0.5 to 1.1 nanograms per ml or lower, or in picomoles per ml, we're looking at between 4 and 8 picomoles per ml.
Mm-hmm. Awesome. I'm impressed.
I passed. All right, so my turn. Is the miscarriage rate higher in people with decreased ovarian reserve versus those without decreased ovarian reserve?
This is a really great question. You have to think about the two things that you're comparing, right? Because you really have to compare apples to apples. Okay, so what I mean is that if most people with decreased ovarian reserve are older, and we know that age is the biggest driver, the biggest predictor of miscarriage risk. In general, patients with decreased ovarian reserve probably have a higher miscarriage rate because their average age is also going to be higher. But if you take, let's say, two people, both of whom are 30 years old, one of them has an AMH of, 5 picomoles per liter, and the other one has an AMH of 25 picomoles per liter, now you're actually comparing apples to apples. And in that instance, we think embryo quality, we think the chance of an embryo sticking, implanting, chance of miscarriage is going to be equal, because that's how important age is in all of this. It is important to distinguish between age and quality versus the quantity of the eggs, which is why we keep saying that over and over again.
Perfect answer.
Thank you. Another question that comes up is, if I'm listening to this podcast and I haven't been to a fertility doctor, but maybe I'm thinking about it, how do I know if I have decreased ovarian reserve? How do I know if I should be worried? What are the symptoms of decreased ovarian reserve?
There's no actual symptoms to decrease ovarian reserve. Once the decrease of ovarian reserve is so severe that you're going into perimenopause or menopause, then you might experience some menstrual irregularities. The perimenopausal period, which is usually the 5 to 10 years prior to menopause, is usually characterized by menstrual irregularity, hot flashes, vaginal dryness. And then menopause, it basically is no menstrual cycles. But decreased ovarian reserve is not the same as perimenopause, and it's not the same as menopause. So a woman with an AMH level of 3 or 4 or 5, she's not in perimenopause, and therefore she might not experience any symptoms of decreased ovarian reserve at all. And that brings me to the next thing I want to mention, which is this idea of doing a test. Like I've seen on social media in the market that there are some companies are there promoting a test of ovarian reserve where you do a urine test and you're basically measuring your FSH level. It's important to know that FSH levels can be normal in people with ovarian reserve. Actually, they usually are, unless we're talking again about perimenopause and menopause, in which the FSH levels are high. But by the time that we get there, then it really is a bit late. So women that have decreased ovarian reserve and are still having regular cycles with an AMH level of 3 or 4 picomoles per mil are going to have a normal FSH. Therefore, if, like you're saying, you're listening to the podcast and you're thinking, hey, do I have DOR? I don't have any symptoms. Hey, I saw this on social media, this kit that I could buy and pee on the stick at home. If it is positive, which means your FSH level is very high, that's certainly a reason for concern and to run to the fertility clinic. But if it's normal, that does not mean that you do not have decreased ovarian reserve and that you do not need to worry about it at all. If you're trying to conceive or not pregnant, or if you're thinking about freezing your eggs, you still need to consult a fertility specialist to get the real lowdown on where your ovarian reserve is, because these kits are not going to tell you the whole story. I can actually be deceiving and steer you away from a fertility clinic when you really should be seeing a fertility doctor.
And along those lines, I think it's really important to emphasize yet again that just because you have decreased ovarian reserve doesn't necessarily mean you're going to have fertility problems or fertility issues. Just because you find out that your egg reserve is on the lower side, you might not have trouble conceiving at all. In fact, I can remember one case so clearly in my mind. I saw a patient for an initial consultation, went through their history. I think she was somewhere in her mid-30s. They'd been trying for a year and they hadn't had any success. So I sent them off for a general panel of testing. And her AMH came back super low. I think it was something like 2 picomoles per liter. That is super low, especially for somebody in their mid-30s. I knew that I was seeing her in a follow-up on that particular day as I was reviewing the results. And honestly, my heart sank when I saw that for her, right? I felt so bad for her. And I was thinking to myself, oh my, this is going to be a challenging conversation. I want to make sure that I explain the information. I was trying to piece together the words that I was going to use to explain this to her and to make her understand, but also not to incite panic, right? To kind of walk that fine line. I geared myself up to have this conversation. I walk in the room and you know what she tells me?
I'm pregnant.
I'm pregnant. And I was like, oh, congratulations. So, I mean, we talked about it, her egg reserve, but it's not like there's anything to do with that point.
Right. Yeah.
But that really stuck with me. Whether your egg reserve is high or low, naturally, if you have a regular cycle, you're releasing 1 egg per month, 1 chance of pregnancy per month. So you could still absolutely get pregnant.
The same thing happened to me. One of my close friends who is an amazing obstetrician. Of course, I cannot tell you her name, but she's incredible. She met somebody and she wants to get pregnant and she hasn't started trying. And of course, being an obstetrician, they thought she would check her AMH level because why not?
Yeah.
And it was super low. And she came to my office completely in tears, panic crying. I got to do IVF tomorrow. I'm like, you haven't started trying yet. Let's just remove your IUD. Get on it and see what happens. First cycle, she was pregnant.
Yeah.
And then she did it again for her second pregnancy. And this is at the same time that I had a very high AMH level and was on my 5th cycle of IVF. While my close friend with an AMH level that's really low, it's having 2 children back to back. So,
and it just goes to show you there are so many pieces, so many elements that have to come together. And this is just one of them.
All right, superhumans, that's all for today. I hope that you found this episode useful. To summarize, decreased ovarian reserve is very common, but you still have lots of fertility options available. Mini IVF is one option, dual stim is another option, and conventional IVF is still an option as well. We didn't talk about it, but it's something that your doctor can discuss with you as well. We have things like add-on therapy, like testosterone therapy and growth hormone stimulation. And remember that it's not a diagnosis of infertility, and natural pregnancies can still happen in this setting.
And that's a wrap for today, superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.